Good morning, Chairman, ladies and gentlemen. Welcome to join the first Beijing Pediatric Minimal Invasive Surgery Live Workshop. It's my honor to introduce our experience on the management of a choledochal cyst in the laparoscopic era. In past 20 years, 2,554 CDC children were successfully underwent laparoscopic HJ in our center, and 82% underwent single incision laparoscopy procedures. Today, I would like to share our experience on the treatment and prevention of post-OP complications, includes hemorrhage, accidental injury, biliary obstruction, bile leakage, pancreatitis, root obstruction. The recognition of pathophysiology, timing of surgery, improvements of surgical technique will minimize the morbidities and maximize the concept of MS. The pathophysiology of CDC includes the distal obstruction, bind the single or multiple hepatic duct structure, aberrant right hepatic artery anteriorly comprising the proximal common hepatic duct, ectopic location of papilla of Vater and PBMU. Majority of pre and post-OP complications results from delayed surgery and link with each other, like perforation-induced dense adhesion, increase the risk of accidental injury. Coagulopathy caused by liver damage induced hemorrhage. Hence, the timing of surgery is crucial. Liver damage and fibrosis is one of the severe consequences of delayed surgery. A large amount of sludge aggravates distal obstruction, results in the liver damage like biliary atresia. In our series, the early cirrhosis occurs at 2 months after birth. The RCT study showed that in the prenatally diagnosed asymptomatic CDC, the cirrhosis was 25%, significantly higher in the group with delayed surgery after 1 month of age. Perforation is another severe consequence of delayed surgery. CDC is a major cause of spontaneous biliary perforation in fetus. In our series, the earliest perforation occurs at 2 days after birth. We categorize perforation into 3 subtypes. The type 1, complete perforation with general peritonitis. It often occurs at the junction of cystic duct and CDC in older children with clinical sign of peritonitis, i.e. abdominal pain and fever, a large amount of eye cells and proton plug in the imaging, mild to moderate elevation of GGT and TB level, and a higher white blood cell. The type 2, sealed perforation with localized peritonitis. It often occurs at the distal CDC and CHD in older children with clinical sign of localized peritonitis, i.e. abdominal pain, a pseudocyst, and a large amount of proton plug in the imaging. The moderate to severe elevation of GGT and TB level. The type 3, intramural perforation, i.e. the mucosal and muscle layer are perforated. Serosal layer remained intact. It often occurs at the distal CDC and CHD in younger infants with clinical sign of biliary obstruction, i.e. the jaundice and mass, extensive distension of the CDC with a large amount of proton plug or sludge debris in imaging, severe elevation of the GGT and the TB level. Our studies show perforation is more likely occurs in the neonates and the infants younger than 1 year old. In perforated CDC, 42% occurs in the infants younger than 1 year old. In overall CDC children, 50% of children younger than 1 year old developed perforation. In perforated CDC, nearly 66% of prenatally diagnosed patients have developed intramural perforation, and 24% developed sealed perforation in early childhood. Physiological results show the liver fibrosis in 42% of CDC children with perforations, and 82% occurs in infants younger than 1 year old. GGT level significantly elevated before the complete perforation. White blood cell elevated in only 49% of patients, and more often in the complete perforation with general peritonitis. Regression analysis and the ROC curve show the GGT higher than the 614 indicate impending complete perforation. The surgical strategy, laparoscopy one-stage surgery, can be carried out in the group 1 patient immediately after the perforation, the sealed perforation and intramural perforation. For those with general peritonitis and poor medical condition, staged surgery are recommended. This example is a 18 days girl. He detected a hilar cyst at the gestation of 4 months. We can detect a large cyst on the CT scan. It is not the stomach. We do the intra-OP cholangiogram. We can see the bile leak from the medial wall of the cyst and form the pseudocyst. So this patient have vomiting. The right side is the video of the laparoscopic hepatic jejunostomy for this patient. We dissect the perforated side along the submucosal layer. And here is the pseudocyst. Fusiform cyst dilatation often underestimated. This is a boy, 2 years old. He has surgery for the long segment HD at 3 months old, and had abdominal pain after 2 years. The ultrasonographic study showed the dilatation of common bile duct is 0.9 centimeters. The laboratory test is normal. So the clinician suggests the patients have observation, and they thought the abdominal pain induced by the intestinal obstruction. At day 5, the abdominal pain became severe, and the laboratory test showed elevated amylase level. CT scan showed large amount of eye size with dilated CDC. He has perforation of the CDC. Hence, he has drainage for 7 days and then do the HJ, repeated perforation. This 2-year-old have abdominal pain and vomit. The first perforation occurs at the junction of cystic duct and common bile duct. Here is the eye size. It's sealed by the surrounding tissues. After the perforation, the abdominal vein was relieved. Laboratory tests also showed the decrease in the GGT level. Hence, the parents and the clinician asked her to have that. After a few days, he has a severe abdominal pain again. The second perforation occurs at the right side of the lower part of CDC. And this the intraoperative image also showed the first perforation at the conjunction between cystic duct and the CDC, and the second perforation locates in the lower parts of CDC is the pancreatic segment of CDC. The intra-OP cholangiogram also show the large amount of protein plug at the distal side of a common channel, which induced the first and the second perforations. Liver damage often induced coagulopathy is a major reason for the conversion from laparoscopic to open procedure, and often induced shock and even death. In our series, 36% CDC children associated with coagulopathy with the fibrinogen depletion. The right side intra-OP cholangiogram show a large amount of stone debris in the distal side of CDC, which induced severe damage, and coagulation tests show not clotting in the PT, APTT, and FIB test. Pathology results showed grade 3 of fibrosis in these 2 months infants. Bleeding occurs more frequently in infants. Majority of the younger infants have subdural hemorrhage requiring craniotomy. The biliary obstruction and the liver damage induce the maldevelopment. Delayed surgery also increased the risk of carcinoma from 0.4% in patients younger than 18 years old to the 38% in patients older than 60 years old. The youngest one encountered carcinoma at 3 years of age. The OP time increased with age. In summary, the disadvantage of delayed surgery increased the OP time, the risk of liver damage and cirrhosis, spontaneous bleeding, pancreatic damage, infection, perforation, and carcinoma. Disadvantage of stage surgery include dehydration and electrolyte imbalance, infection, adhesion-induced unclear anatomy, also increased incidental injury in the second stage surgery. Hence, early definitive surgery is advocated. In the era of laparoscopy, the laparoscope with magnified surgical wheel allows precise dissection and anastomosis. It significantly decreased the morbidity in neonatal CDC and make the early surgical intervention in neonatal period to be possible. In our series, the prenatally diagnosed CDC increased from 90% to 40% from 2011 to 2019. We can detect before the 2016, majority of the prenatally diagnosed CDC have surgery before 1 year old because of their clinical signs. But after 2016, with the recognition of the physiology and early surgical intervention, they underwent surgery before 1 year old because they have a very close monitoring when the ultrasonographic study and the laboratory results show the damage of the liver and aggressive dilatation of the cyst, which indicates the distal obstruction aggravation. The conversion rate of single incision laparoscopy hepatic jejunostomy also decreased because the early surgical intervention. Our series also show before 2016 the redo surgery, the surgery for the perforated CDC, stage surgery, and surgery for giant CDC increased because we expand this technique to the complicated CDC. But after that, it dropped down because the early surgical intervention. In 2019, we compared the results between uncomplicated and complicated CDC. The OP time in uncomplicated CDC is 1.5 hours, significantly shorter than 3.8 hours in complicated cases. The post-OP recovery in uncomplicated cases also faster than those in the complicated cases. Improvements in surgery. To prevent the hemorrhage, correction of coagulopathy before the surgery is necessary. And intra-OP, we have a double-layer suture closure of intrapancreatic dissection area to prevent post-OP hemorrhage. Prevention of vessel injury, we use the retraction suture to increase distance between the artery and the choledochal cyst and CHD to facilitate the dissection and anastomosis without injury of the vessels. We also transect the CDC from the proximal side. Hence, we can detect the hepatic artery and portal vein from the transection level and dissect the CDC close to the cyst wall to avoid the injury of portal vein and the hepatic artery. This gastroduodenal artery anteriorly comprising the choledochal cyst in the mid portion, we use the retraction suture and assistant to put up the retraction suture to increase the distance between the gastroduodenal artery and the cyst to prevent the injury. To prevent the injury of hepatic duct, we transect from the proximal CBD and detect the HD orifice in direct vision to prevent the injury of hepatic duct. In the staged and reduced surgery, the adhesion is dense, so we do the dissection along the cystic duct to the common bile duct. The jumped dissection should be avoided to prevent the injury of right hepatic duct and portal vein. Duodenal injury have two types. One is perforation, the other is anatomical variation. In the dissection, we dissect the cyst along the submucosal layer to prevent this injury. In case the injury occurs, previously we often convert to the open procedure. Now we place the retraction suture at the end of the distal end of CDC to expose the injury of duodenum, and then we do the suture using 5-0 PDS suture. After repair of the injury, transect the distal of CDC. Prevention of AHD injury and bile leak. The AHD categorized into 4 types. The type 1, the aberrant HD locate at the junction between the cystic duct and the common bile duct. It can be combined with one stoma or suture the lateral of AHD and CHD to form a stoma. The type 2, aberrant HD located in the mid portion of a cystic duct. The separate AHD to duodenal anastomosis and CHD to jejunal anastomosis were carried out separately. Duplication of cystic duct. The duplication should be ligated before incision to prevent the post-OP bile leak. The type 4 is combined with the aberrant right hepatic artery. If the right hepatic artery anteriorly crossing both AHD and the CHD, it will be replaced behind the CHD. If the aberrant RHA anteriorly comprising the CHD alone, we transect the AHD from the CHD and reposition the RHA behind the CHD and suture the AHD and the CHD as one stoma. Bile leak repair. Bile leak include anastomotic leak. We can perform the laparoscopic repair. The aberrant HD also induce the bile leak, particularly in the perforated CDC or reduced surgery. The laparoscopic AHD jejunostomy are carried out. To prevent post-OP biliary obstruction, the first one is anastomotic stricture. We need to improve the anastomotic skill. Second, we need to secure a tension-free anastomosis. Third, we need to preserve adequate blood supply. The proximal dissection level should be accorded with the anastomotic level. We need to reserve the adequate caliber of the anastomosis as well. Aberrant RHA and HD stricture are major causes of post-OP biliary obstruction. We need to replace the aberrant RHA behind proximal CHD and split the stenotic segment of HD into the proximal dilated segments and do the wide HJ at this level to prevent the post-OP obstruction. To prevent post-OP pancreatitis, the proton plug in the common channel should be removed by either the catheter or the cystoscopy irritation. Prevention of Rook's loop obstruction. Previously, we used 35 to 40 meters based on the adult standard. It often increased with the age. So the redundant Rook's loop often induced rotation and obstruction, even necrosis. We here is tailored individualized short loop according to the distance between the umbilicus and the hepatic hilum. Our results show the anti-reflux effect is similar to the long Rook's loop and prevent rotation and necrosis of redundant loop. In conclusion, recognition of pathophysiology, optimal timing of surgery, and improvements in surgery can minimize the complications. If the complication occurs, the early treatment of complication is advocated, hence to maximize the minimal invasive surgery. Thank you. So let's move to the section of Q&A. Welcome to address your question. Thank you.
That was a wonderful presentation and a lot of hard work. I have a lot of
thank you.
Admiration for that. I just have a few questions. I mean, some part of the world, say Australia, people are hesitant to do the operation at this young age. You do it up to sort of neonate. Now, then people need some evidence that this can prevent liver fibrosis. I just wonder, from the liver biopsy specimen, whether those kids of neonatal age have less cirrhosis than the kids, say, older kids. I'm just trying to see if there's any evidence of prevention of liver fibrosis by early surgery.
We detect, because we closed work with ONG department in other hospital, and they have a routine prenatal ultrasonographic study to detect whether they have the cyst at the hepatic hilum. And then if we found the cyst, we have a closed monitoring, and they will repeat the ultrasonographic study 2 to 4 weeks. If the cyst increased very quickly, it indicates the distal obstruction of common bile duct gravis. Mostly they have a large amount of sludge inside, as shown in the slides, and it will induce the complete distal obstruction, similar to the biliary atresia. You can see in the intraoperative cholangiogram, the contrast agent cannot go into the duodenum. The liver damage induced by the distal obstruction induced fibrosis and cirrhosis at very early stage. The earliest one of cirrhosis occurs at 2 months after birth. And it's also induced perforation. The earliest one occurs at 2 days after birth. Based on this evidence, we suggest we have a very close monitoring for those prenatally diagnosed CDC. If the ultrasonographic study and laboratory tests show the distal obstruction aggravation, we suggest they come to the hospital and do the early surgical intervention. Thank you.
Thank you. That's very nice. Prof. Tam, maybe you have some more addition.
We have 2 questions from online. One is how does the Beijing team do an early detection of choroidosis from asymptomatic patient? I suppose this one was addressed by antenatal screening from your collaborating obstetric department. The second question is, what's the strategy if the proximal HT is too small for good anesmosis? So, maybe Professor Jiao can.
Thank you for the question from the floor. We set up a network with ONG doctors in mainland China, and the patient also upload their ultrasonographic study and laboratory test online, so we can give them direction, give them guidance. When is the optimal timing for the surgical intervention, and what treatment is optimal for them? The second question, to obtain the adequate caliber of the hepatic duct, the stoma in the hepatic duct site, we split the anterior wall of the CHD to get the adequate caliber. For the small infants younger than 1 year old, the diameter is larger than 0.5 centimeters. For the older children, it's larger than 1 centimeters. Thank you.
I have one question for you also. Of course, in Beijing, you have one of the largest experiences in the world, and achieve this admirable result. In the rest of the world, the problem could be the small number of cases they see. So, can you advise on the learning curve of laparoscopic choledochal cyst excision as to what the number of cases the center will need to perform before they can expect to achieve competence? And so any advice for those who have smaller number of cases centers?
Thank you for the question from Professor Tam. Yes, we have a large volume of patients, so we accumulate the experience in a very short period. So we suggest the HBP surgeon and all the laparoscopy surgeon visit those centers and learn have a training in the in center with the high volume of patient and learn from the experience from those center will shorten the learning curve. In our experience, for the conventional laparoscopy hepatic jejunostomy, after 35 cases, our OP time significantly dropped down from the 7 hours to the 5 hours, then to after we accumulate experience of 200 over 200 patients, the OP time dropped to the 3 hours in average. So welcome to our center. Thank you.